Assalamu alaikum, the clinical day. The first scenario, Mrs. Sophia Adam. She's 28 years old, female, presented with right leg weakness. Please sit with her, examine and address her all concerns. If we're ready, Dr. Ibrahim and Dr. Huda, we can start.
Yes.
Here you go. Ibrahim, you can start.
Hello,
Hello.
my name is Dr. Ibrahim. I'm the doctor of the clinic today. May I
Yes.
confirm I'm talking to Miss Sophia,
Yes,
29
doctor.
years?
Yes, doctor.
Miss Sophia, I am here today to discuss your complaint.
Yes, please, doctor.
Can you tell me what's your complaint?
Yes, I have a weakness in my right leg, and I came to know the reason for it.
And can you tell me when this weakness started?
It started 2 hours ago. Yes, 2 hours ago.
2 hours ago. And is this first time you complain?
Yes, this is the
This
first
weakness?
time. Yes.
And is it start sudden or a gradual in onset?
Yes, it's sudden.
And, is it weakness or complete loss of movement of your leg?
Yes, I felt that I could not move my leg completely.
Only one leg? Only one side?
Yes, only my right leg.
All of a sudden.
Yes.
You didn't feel any associated complaint, pain,
No,
swelling,
no,
any discoloration of skin?
no.
You didn't feel anything help you to move your leg?
I tried to move my leg with my hand. Yes. But it just lasts for a few seconds, and after that I was all okay.
And
Yes.
you didn't feel any other weakness in other side of the body?
No,
No swelling?
no swelling.
You didn't feel any hotness?
No.
And you didn't feel your pulse, your heart pulse, palpitation?
I have heart racing for about a month now. Yes.
And you didn't seek medical advice?
No.
And there is no loss of conscious or something like this? And
No, just weakness, doctor.
just weakness for these 2 hours?
Yes, and it's completely gone. I'm okay now.
It's completely gone?
Yes.
And during this weakness, was there any loss of sensation in your leg?
No, but maybe some numbness in my face, in the left side of my face, a slight numbness. But yes, other than this, no weakness.
Other than this, no weakness.
Yes.
And I talk about sensation. Do you feel any loss of sensation? You are can feel your legs. If you touch your legs, you can feel during this?
No, I didn't feel my leg. I lose control over my leg completely, doctor.
For 2 hours and now disappeared?
No, not for 2 hours, for a few seconds. And after that, it was normal.
Just a few seconds?
Yes.
And this, and after that was not become
Yes.
normal
Yes.
and no pain.
No pain.
Mhm. Okay, I will ask you some questions. Did you feel any recently any loss of weight?
No loss of weight. No.
Feel any high temperature, hotness, feeling of
No. No
hotness?
raising. No. No raising in my body temperature. No.
No rash in your skin?
No.
And did you feel any swelling, joint swelling?
No.
And did you feel any chest pain?
Sometimes I have on and off chest pain.
Mhm.
That's like dull chest pain all over my chest, not a specific side.
Mhm.
With this heart raising. Yes, but
Uh,
I didn't seek any medical attention for it. I came recently just for my leg. Yes.
mhm. You didn't seek medical attention.
No at
And
all.
any cough,
No cough.
any breathlessness?
Sometimes I have difficulty in breathing when I do activities. Yes.
Just with activities.
Yes.
And when you sleep, there is no problem with your sleep, no snoring,
No.
no breathlessness.
No, my sleep is okay.
Your sleep is okay.
Yes.
And what about your tummy? Do you have any problem?
No, no problem in my tummy. No.
Swelling?
No.
There, you have no loose stools or
No.
constipation or hard
No.
stool?
No. No. No, doctor.
No change of color of stool?
No.
Is there difficulty in swallowing?
No.
Mm. And is there any swelling in your neck?
No swelling. No.
Did you feel any tremor?
No handshake. No.
No handshake. What about your water work? Is there a change in color?
No, it's normal.
And is there any pain?
No.
No pain
No pain. No.
with urination. I'm sorry to ask you, is there any ulcers or lesions in private area and genitalia?
No. No soreness in any part in my body. No, doctor.
And let me ask you, do you have any past medical history, any admission, any medical problem?
I've been admitted when I was a child, when I was 4 years old, to the hospital. This is my first admission, and I don't know. I was didn't know the reason for my admission at that time.
Or you don't know any details might help.
Yes, they say that I have rising in my body temperature at that time, and admitted for a few days, taking some medication, and I was discharged.
Mhm. After that, there is no admissions.
No, no,
Any surgical operations?
no,
Did you feel any problem in your eyes before?
no,
Any treatment or over-the-counter treatments you are taking?
no, doctor.
And I'm sorry to ask you, mm, be sure everything we are seeing here is confidential. Uh, did you take any illegal drugs or
No, doctor.
um, uh, do you smoke?
No,
Are you taking alcohol, drinking alcohol?
no, doctor.
And I will ask you, I'm sorry to ask some private question. What about your marital status? Are you married?
Yes, I'm married and have 2 children, doctor.
And you didn't encounter any problem during your pregnancy?
No, at all.
No abortion happened to you before?
No, doctor.
And was it normal delivery?
Yes, doctor.
Mhm. And you didn't receive any contraceptive pills?
Yes, I use contraceptive pills.
And nowadays you are using contraceptive
Yes,
pills?
doctor. Yes.
I'm sorry for what you are suffered today, and I hope to find a diagnosis for what happened. But I want to ask you, do you have any more concern you want to tell me about?
No, doctor.
Okay, Miss Sophia, from your history, from information you have said to me, I think you had a condition we called transient ischemic attacks. Did
Okay,
you
so doctor,
know
do you
about this?
want to examine me first or?
Yes, I will examine you and do investigation to confirm the pro- the diagnosis.
Okay, doctor.
Okay. I want to start the examination now.
Okay.
We will start by vital signs. Is there any high temperature?
Temperature normal, blood pressure within normal, pulse rate 100 regular.
100 regular.
Mm.
And symmetrical, both sides.
Yes,
And what about the body belt?
it's normal.
Not
Body mass
obese.
index 25.
25. Okay. Is there any nail changes
Normal, no changes.
on or clubbing?
Negative,
Any tremor or fine tremor or flapping tremor?
negative,
Any wasting in small muscles of hands? Any swelling in joints?
negative,
Negative. Any pulmonary erythema?
negative,
Okay. I will go now to the eyes. Is there any pallor?
negative,
Xanthelasma? Is there any xanthelasma?
negative, no abnormalities.
No xanthelasma. Any no jaundice?
Sorry,
Is there any yellowish discoloration jaundice?
no, negative.
Okay. What about the mouth? Is there any cyanosis or ulcers? Mouth or mouth
Negative,
ulcers
negative.
or the dental caries? And for the neck, is there lymph nodes? Any palpable lymph nodes?
No, negative,
No, and
2 minutes
is there
left.
red PVB?
negative.
And from to the cardiovascular now
Yes,
examination. Is
there
the pulse apex beat normal
there is mid-diastolic murmur, rumbling in the mitral area.
in the mitral area? Mid-diastolic murmur. Is it increased when lying in the left lateral?
Yes, doctor. Radiate to the axilla, yes.
Mhm. Radiate to the axilla, diastolic murmur.
Mid-diastolic rumbling
E-
murmur, radiate to the axilla.
Radiate to the axilla. And is there any first heart sound? Is it loud?
Normal finding other than the murmur.
Other than the murmur, normal finding.
Yes.
What about the chest expansion? Is it normal?
Yes. Normal.
In the lungs, bases of the lungs,
Clear chest.
clear chest. And is there any liver enlarged liver?
You can pass the
You can pass. Okay. What about the examination, neurological examination of the leg now? Is there any
now
weakness?
weakness normal.
Normal.
Tone
Sensation
power
normal?
reflexes. Yes, tone power reflexes and all four modalities of sensation.
They are normal. And there is no bruises in the body or no any rash?
Negative.
Negative. Okay, from the history and from my examination, I think that you have, Miss Sophia, you have something called, you had something called transient ischemic attacks, and this is, do you know this disease?
No, doctor.
I'm sorry for your suffering, and I will explain to you. This transient ischemic attack is transient shortage of blood supply to some area in the brain. Okay, and this one this happens temporary and the blood regain flow to the brain. This will cause this might be the cause of what you felt in your leg. And from my history, I find you have the only thing might be predisposing this condition is your contraceptive pills. Do you follow me?
Yes, doctor.
And I'm sorry for your suffering again, and appreciate your complaining. And our plan of management for this problem, it will be depends on trying to consultate you about the problem, in addition to try to avoid any precipitation problem. And
Okay.
we
Well, yeah, time
finished.
is out. Yeah.
Okay.
Already time is up and 2 minutes was added. Let's go to the examiner
Okay.
question. Well done, Dr. Ibrahim. Let's start the examiner question. Please, Dr.
Yes. Can you present your finding?
My finding on examination, the patient most likely has mitral stenosis, but mid diastolic murmur of mitral stenosis. This is the only positive finding in examination, as I remember. And by the way, the mitral stenosis usually doesn't radiate to the axilla. That's why might be there is mitral stenosis and associated with mitral regurgitation. If you feel any axillary and any radiation of murmur in the axilla, might be systolic murmur and confused. But if diastolic murmur of mitral stenosis doesn't radiate to the axilla, it will be tapping apex beat. It will most of the time has loud first heart sound. Okay, but I didn't find loud first heart sound in this patient. Might be due to heavily calcified valve. And this patient is receiving oral contraceptive pills, and these two factors are predisposed to CVA or transient ischemic attacks sometimes, but we still need to confirm the diagnosis. And most of the time, the CT scan or MRI will not find any any changes in TIA and transient ischemic attack. That's why we should take our precautions for patients like this, and consult the patients and give them the appropriate way to try to avoid other attacks, and do basic investigation like CBC to check for any polycythemia or something like might also predispose to something like this. And we should do ESR and CRP, because young females might have myxomatous change in the mitral valve, might cause these diastolic murmurs, and might predispose to TIA. And we should do echo, and we should do Doppler ultrasound for both carotids to see if there is any predisposing problem. Also, we should send for cholesterol levels and lipid levels to check any also things might predispose this to this condition.
Okay, so other than the valvular lesion and clot precipitated to TII, anything in the history maybe give a clue to this valvular lesion?
The palpitation, only the
Okay,
palpitation from time to time, and chest tightness.
So the differential diagnosis would be the top differential TIA, other differential.
Other differential diagnosis, because the multiple sclerosis might do attacks like this, but usually the patient will has several attacks. It will not be single attacks, and
Okay, doctor. Thank you.
Thank you. Any comment?
Yeah, still a 30-second question. So you said about some investigation. What image you want to do in this patient?
ECG, imaging, echo and ECG,
Okay.
and scan or MRI brain.
Okay. What else?
And Doppler ultrasound for the carotids.
Perfect. Yes. Okay. If this patient told you I have some awareness of heartbeat and it's irregular, what other tool you can add to investigate?
Halter, because he might get paroxysmal AF as a complication.
Perfect. Okay, perfect. You mentioned MRI, right?
Yes.
Yeah, it's important also to do. I think the time is up.
But also I mentioned it's usually normal in TIA.
Yeah. Diffusion scan, it will be mostly normal. Perfect, Dr. Ibrahim. Let's hear Dr. Huda comment, then I will comment. And try to find a case for her, please. Okay.
Okay.
Dr. Huda, you can start.
Yes, this is a case of transient weakness, TIA. First, it's precipitated by childhood infection with the rheumatoid fever. As she mentioned, when she was child, she has admission for a raising body temperature. So the precipitation factor for the valve lesion is rheumatoid fever in the childhood. With associated this weakness, transient weakness. So first, and throughout the history, maybe most importantly, to do a specific analysis of any weakness by asking where the side exactly, whether the leg is a floppy or stiffy. She will told you she have a stiffy more than a floppy leg. You ask about any sensory loss, any changing in the way she walks, and then we do more CNS analysis, and you do it throughout your history, any deviation of mouth, any droopy eyelids, dizziness, headache, very important in this case, headache to exclude migraine. And then important to ask about risk factor for stroke, any high blood pressure, sugar, cholesterol, family member with increased cholesterol, more asking about the smoking history also. Then we go to the cardiovascular system. If you explore more in your history, because she told you that she have a raising in heartbeat, so explore more about the chest pain. You ask about difficulty in breathing. Yes, so CNS full analysis and cardiovascular full analysis will give you a clue to the diagnosis. Also, maybe doing some exclusion for multiple sclerosis, asking any previous admission, any painful eye movement, because she's a young lady with
I asked already.
yes, you asked about multiple sclerosis. Maybe more specific about migraine. You ask about the headache, but more any zigzag line, abnormal taste in your mouth. Maybe asking more about any abnormal movement to exclude fits. The systemic review, okay, you explore throughout the muscular skeletal system, explore the endocrine system, and the urinary and the GIT. But the history would be mainly focused on the CNS and the cardiovascular. Throughout the examination, most importantly, to start from the main complaint, which was the leg. So doing the Babinski, the tone, the power, the reflexes, and two sensation, maybe fine touch and proprioception. And then examine the cardiovascular examination. That include any murmur, adding murmur, chest for crepitation, and explore through pulse, checking the pulse, and maybe the carotid bruit, also very important. Yes, so this is a young lady with, and maybe you can add if the time, the upper limb examination, maybe doing just pronator drift or simple reflexes. Yes, so this is and in the social history, she told you she have using oral contraceptive pill. So maybe advise her to see what we will discuss with the women doctor, because clots also a high risk for weakness in young female. Regarding that's all my notes.
Okay, thank you, Dr. Huda. Very nice case. And it's unique case. Rheumatic heart disease in the childhood, complicated in the adult age with TIA. So it's classical case in the exam. You have two system affected the heart as well as the CNS. And both of them will give you finding. Suppose if it is a stroke, but this is TIA, so everything disappears. The performance also for Dr. Ibrahim, although he's very quiet, but he did everything. Really, you need just to be raising your voice to be more confident. But everything you did is great. Apart from, I will comment about the system you missed, which is the CNS. A lot of question in CNS you have to ask in any presentation with this. Okay, of course, as Dr. Huda said, either to ask the weakness, is it floppy or stiff? This will guide you to upper or lower motor neuron lesion. I prefer to ask to what level this weakness. Is it to the knee, to the hip? Because you don't know where exactly, because it's already disappeared. You know, you have to know where exactly the level of the weakness. Is it distal? Is it proximal? Why? Because it gives you a clue about the area affected in the brain. Apart from this, the hand as well, any weakness in the same side.
Yes, I
And
asked
when
about
she,
it.
yeah, okay. When she mentioned she has some asymmetry in the face, you have to think about brainstem and cross lesion, right? So you have to correlate. Is it same side or different side because it will guide you to either brainstem or to the cortex and subcortex, right?
Yes.
This is about localization. Okay, apart from this, you have to ask about sleep and stress and mood because this is female in the childbearing period, and all female in this age, you have to rule out stress as a convergent disorder. You can put it in the differential safe if you mention it is convergent disorder, which is subsided after relief of the stress. The next thing you have to do in the CNS, all questions for CNS, the hearing, the vision, smell, and speech, balance and steadiness, all these questions, pins and needles, all this question would help you to know if there is other area or zone in the brain affected. Really, the history taking and the system review, the questions, apart from what you missed, is perfect. Just to speed up, just to speed up your question way to be more fluent and raise your voice to show the examiner that you are too much confident. I know you are confident, but just show the examiner that you are confident and you reach diagnosis and you give good if differential. And during the examination, and the examiner start to ask you, he asks you one question, answer according to his question. So he told you what is the positive finding in the history. Tell the positive finding in the history, then be quiet. He will give you another question. If you keep
Yes.
talking, he might cut the mark because he didn't judge on the other things. So let him ask you more and let him judge on your clinical judgment in this 5 minutes. You give everything in that 4 minutes, mashallah. You give all the answers. Investigation, management, addressing, everything you did. Yeah, by the way, the job you didn't ask, right? The job and the driving.
Yes.
If
Yes.
she has some vision problem. Yeah, perfect, Dr. Ibrahim. Really, it was amazing. And the case also was amazing by Dr. Hoda. Thank you, Dr. Hoda and Dr. Ibrahim. Any question from
May I
you
ask
or
a question?
yeah, yeah.
Usually in Marcy B Irish, can I write notes? Yes?
Yeah, any note, any exam, sorry, in any exam you have paper, you can write. Yes, not only Irish or the UK.
Yeah. Okay.
I don't know also you miss the examination or you were about to do the examination or you forgot it.
In Irish, you just will do the examination as they
Yeah,
write, but he is actor. You will not find any finding.
not necessary. I know some doctors in Irish, they have uh, real patient. So you might have real patient. It's not necessary to be a surrogate. Okay. Be ready for examination even. I know you
Yeah.
have 20 minutes, so you have good time to do examination, all examination steps. But just in case, be ready for
Is
everything.
it 10 minutes for examination?
No, 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 it's not like that. It's 20 minutes.
Yeah, yeah,
And
10
do
for history and 10 for examination. They got divided.
no, no, it's not necessary to be like this. If you finish at 8 minutes, you want to do examination, you can do 12-minute examination. So
Mm-hmm.
it's not divided. Okay, they
Yeah.
not they are not dividing and they are not telling you. Some examiners saying yes, 10 minutes left, and
Yes.
according to your history, you want to take more. You want to do examination, but it's not necessary to be 10 for history and 10 for examination. Do whatever
Mm-hmm.
you want in the 20 minutes and try not to finish before 20 minutes because they might start asking you before the examiner time and they will judge you on more examination and clinical judgment questions. Okay,
Mm-hmm.
but perfect. Thank you, Dr. Ibrahim. Nice
I hope
case
so.
and nice presentation and nice performance. You have a case now for Dr. Hoda?
I think so.
Okay, just write it and I will try to listen to other comment. Anyone has comment, please? Any suggestion? Any added point to the case? Okay, Dr. Rashid comment. Once you came upon chest symptom, with history of weakness, ask for noisy chest. Yes, Dr. Rashid. What's the relation of noisy chest? You mean eosinophilic, right? To the weakness, as the case presented before, right? Or you have another suggestion?
Yes, I mean this point is
Perfect. Okay. Musculoskeletal symptoms important. Yes, he asked, I think, about joint pain and skin rash. I think he repeated the question for skin rash. You have any skin rash while he analyzing
Yes.
the complaint? Then you ask it later. Yeah, try to avoid not to double the question. Dr. Ala wrote, mitral stenosis paroxysmal AF led to TIA function disorder. My differential perfect, Dr. Ala. This is also mine. I was thinking about periodic thyrotoxicosis periodic paralysis, but Dr. Huda surprised us. She changed the diagnosis. On background, Dr. Maha, on
he
background
was
of rheumatic heart
Dr.
disease.
Basim.
Mhm.
He was asking about the as a site of weakness at the beginning,
Yeah, yeah,
redness, changing, swelling,
yeah,
as he
yeah.
searching for some cellulitis or DVT, something like that.
Mhm,
At that time, he should ask about CNS, I think. Then in systemic
mhm.
review, she had asked for this musculoskeletal, I think.
Yes, yes. Yeah, he did. He missed only in the female history. You can add it to your questions. Three P's, as we know. You ask about birth control pills, but you ask in OCB, but try to make it as birth control pills, pregnancy, and try to know the last delivery, as you did, and any event happened with the last delivery. And the last question is the period. Sometimes it guide you to the case if there is thyroid or hormonal disability. Okay, Dr. Ryan, she attended today. She was absent, I think, for 3 or 4 sessions, but she wrote a comment now. Mitral stenosis murmur doesn't usually radiate to axilla. Perfect, yes.
I
It's
think when the patient saying I'm using contraceptive pills, there is no need to ask about periods, yes?
no. You might ask because if you suspect thyroid,
Uh-huh.
she might tell you, yes, I had before some change, some irregularity,
Yeah.
but not in this case because here negative
Yeah.
thyroid.
Yeah.
Okay, just post your case if you find it. I will read the other comment. Dr. Maha again. History of admission when she was young indicate rheumatic heart disease. Perfect, yes, exactly. Dr. Abdullah Hisham. Admission in childhood due to rheumatic heart fever or rheumatic heart disease or rheumatic fever resulted in rheumatic heart disease. Yes, exactly. Stress, this is my comment. Stress in young female to rule out convergent disorder. Yes, Dr. Ala commented. Yes, functional disorder need to ask about mood, stress at work and home, and add to them the job. Pronator drifts you miss in the examination, Dr. Ibrahim. Always remember to do it and to do
What's it?
reflexes. Pronator drift as well as Babinski. Although
Mhm.
although it will be negative in this condition, you have to show the examiner that I am checking for upper motor neurology. It will be positive if there is stroke. Pronator drift and Babinski, it will be upgoing, plantar.
Yes, yes. I think when she said on neurological examination is normal, she want me to pass. That's why I stopped.
Yeah, yeah. Okay. Dr. Ma, I expected heart racing with pulse will be irregular like me to be thyroid. Could someone share the case? Dr. Ahmad Reba. Yeah, it was Mrs. Sophia, 28 years, female, present right leg weakness. Dr. Rashid, good comment. Dr. Ryan, mashallah, he did great job. Need a little to be organized and avoid jargon. Yes, agree. Thank you, Dr. Maha. Thank you, Dr. Huda and Dr. Ibrahim for a nice session. Atrial myxoma, a good differential. Perfect, Dr. Ryan. So, Dr. Ryan, tell us what if there is atrial myxoma, what you will find in the examination.
Assalamu alaikum, Mr. Basim. How are
Walaikum
you all?
salam. Fine.
So actually, he mentioned it when he was saying his
Perfect.
presentation
Yes,
of
he
the
mentioned
case.
it.
It was
Yes.
actually a perfect, differential. the difference would be in the change of the يعني atrial myxoma murmur will change with the position usually.
Okay, what
Uh,
else? This is heart examination. What peripheral examination you could find? Peripheral sign.
in atrial myxoma, you mean?
Yes.
I am not quite sure.
I think
He
clubbing.
asked about the nails. Perfect. Yes, he asked about the nails. I guess Dr. Ibrahim, he asked like hidden questions for something he want to.
Which in the
The,
nails? I did not get that.
the nails,
Clubbing.
clubbing. Who said
Clubbing,
clubbing?
yeah.
You, Dr.
Yeah,
Ibrahim,
yes.
or someone else?
No,
لا,
me,
someone
Dr.
else's.
Sakinari.
Yeah.
Okay. Yes, clubbing in atrial myxoma is pathognomonic for atrial myxoma.
Yes.
Perfect. Perfect, Dr. Bakinam. Yes, it is the
And I
finding.
think the first heart sound will be not accentuated also.
Yes. And also, as Dr. Ryan said, the murmur will be changed with the position.
And
But
the weight
it's
loss
still,
constitutional symptoms, yeah.
this is Dr. Aisha now, so yes. Okay, perfect, Dr. Aisha. Weight loss, clubbing, and it would be a differential for any mid-diastolic murmur. Atrial myxoma, mitral stenosis. Both of them are differential to each other. Okay, did he examine the pulse? Yes, he examined the pulse. He asked by name any asymmetry, and he asked also about the pulse
ايوه يا باشا
regularity.
بص قال لي ايه فيب اه
Okay,
ايه فيب ايه فيب
okay.
Give me a minute, okay?
Yeah, take your time. We will read the other Dr. Baim. This housebound elderly woman has become more malaise. So this is your case. I put the case a few minutes to prepare. Okay, take your time. We'll open the discussion. Anyone has comment for this nice case? Really, Dr. Huda, you prepared the case very nice. It was a unique case. We didn't do before. See how many session we did, but we didn't do it in this way. Rheumatic heart disease in the childhood, or rheumatic fever, which complicated by rheumatic heart disease, and mitral stenosis complicated with propagation to thrombosis and TIA.
Okay,
So
thanks.
let's discuss about the case. Yeah, Muswad.
But
I will ask you. Yeah,
my now is
yes.
malaise. My case is now malaise.
Yeah, he didn't complete it, so we are waiting for him.
Okay. I thought it's to prepare.
No,
Okay.
no, still he said he
Okay.
will write it. Okay,
Okay.
let's ask about this condition as rheumatic heart disease. Anyone has criteria for rheumatic heart disease? Anyone remember the diagnostic criteria, like DOC criteria and rheumatic and the infected endocarditis?
Yes, the rheumatoid fever criteria. It's major criteria and the minor criteria.
Okay,
Right. The major criteria is joint. They will have polyarthritis,
perfect.
carditis. They have a nodule, subcutaneous nodule that's not tender on the elbow, I think. Erythema marginatum, not blanching, not pruritic, and Sidman chorea. So joint,
Perfect.
carditis, nodule, erythema marginatum, and Sidman chorea. This is the major criteria. The minor criteria, it's raised ESR and C-reactive protein, pyrexia with arthralgia, and on ECG prolonged PR interval.
And
Prolonged PR interval.
last one, previous rheumatic fever. Yes.
Yes, there is evidence of infection,
Yes.
of streptococcus infection, a history of scarlet fever, positive throat swab for streptococcus, يعني increase
Perfect.
DNA beta
Yes.
titer, I think. Yes. So
That's
it is
perfect.
autoimmune process following group A streptococcus. Yes.
Yes. I have a figure to share it now for abbreviation of this criteria. Wait a second, just I'm trying to share it. Okay. I will share it to the group. Then someone can share it here. Yes. I hope you can see it now. Dr. John's diagnostic criteria. As Dr. Hoda mentioned, major and minor, the same as Doc's criteria. Cases, FRAP. This is abbreviation, cases FRAP. C for carditis, A for arthritis, S for subcutaneous nodule, E for erythema marginatum, S for Sydenham chorea. The minor, FRAP, the fever, F for fever, R for raised ESR, CRP, arthralgia for A, P for prolonged PR, and last P for previous rheumatic fever. It's clear in the WhatsApp group. I cannot share it here, but I will try again. Okay, and let's ask one more, because you prepared the topic well, Dr. Hoda, right? What's the management plan for rheumatic fever?
Actually, I didn't prepare the management plan.
Okay, let's make it as a general rule for any case in cases. We have to say multidisciplinary team approach. This is multi-system affection, right? What do you think? What the team you can include in this patient?
Dermatologist, rheumatologist, and
Yes,
cardiologist.
yes, and also might affect the kidney, right?
Yes, you're right.
Okay, this is for the multidisciplinary team as a first thing to mention as the management plan. The second thing you can say non-pharmacological and pharmacological. What do you think about non-pharmacological?
Vaccination.
Counseling about the disease complication. Always make it as a scheme. Counseling about the disease and manifestation and complication. Okay. I don't think here there is vaccination in rheumatic heart disease.
Yes, they
I
will
don't
have
think.
vaccination till 28th of age.
Yeah, you mean
28
for the
year olds.
streptococcal.
Yes, yes, yes.
Okay. Apart from that, the medical management or the pharmacological, what are the options and what is the next option after medical?
Surgical.
Penicillin.
Yes, perfect.
Dental
So,
penicillin.
yeah, by the
Mm.
way, the most common mitral valve disease in female is stenosis. And the
Yes, you're
most
right.
common of mitral stenosis is rheumatic heart disease. So
Yes, you're
you
right.
have to prepare yourself for this topic, mitral stenosis,
Mm.
as a finding either in the short or the long. It might come in the short, it might come as long. And the management plan for medical and for the surgical. What do you think about the medical? What you can give to this patient, particularly this case and for other patient with mitral stenosis? We didn't talk about TIA in this
Yes.
discussion, right? So what you will give him? What you will give here? Patient presented with TIA recently. What you want to start here on?
Chat VASC. We will calculate the chat VASC.
She already had TIA.
Okay, okay, you're right. Yes.
Yeah, she had it. So you
Yes,
will
yes,
start her on, first of all, loading with aspirin and Plavix,
yes.
and dual antiplatelet for 21 days. Then long
We will
life.
continue with Blavix
Yes,
and
long life.
Apixaban.
Why Apixaban?
No, it is not Apixaban. If there is surgical option like mitral valve replacement, we will continue with what is that? Warfarin. Warfarin
Yes.
is preferred. Yes.
Yeah, so you cannot give in valvular heart disease
Yes, yes, you're
NOAC
right.
or
Yes,
direct
you're right.
oral anticoagulant.
Yes, warfarin is more effective than NOAC.
Okay, for the MS as anticoagulant,
I
did you
think
read this point?
once the patient has a complication, TIA, he should have surgery for his valve.
There is other indication. We'll talk about the surgical option or indication
yes.
for
There
mitral
is
stenosis.
criteria. Yes, there is
Yeah,
criteria.
there is. It's not only TIA.
Yes, you're
Okay.
right.
Okay, let's talk about the anticoagulant for mitral stenosis. You said vitamin K antagonist, right? Which is what warfarin.
Yes,
How
warfarin.
much your target?
Warfarin, sorry, if there is AF, but if there is no AF, also you shall use warfarin.
Yes. You will use
2.5
your
to 3.5. I think 2.5 to 3.5 in mitral.
This is
Or
with or without.
Prosthetic
Yeah.
valve.
There is indication for anticoagulant if there is AF, and without AF, there is indication or no?
because of TIA, you mean?
No,
Yes,
for
there is
TIA,
indication.
TIA score 2, yes.
yeah, for TIA already you started antiplatelet. Will you start
Antiplatelets,
this
yeah.
patient on anticoagulant?
For
No, I
prevention
think
or just
I think in this
post-valvular?
case, not antiplatelet. We should start anticoagulant
Why anticoagulant?
because the pathology here is different. Yani patient mostly embolic from mitral stenosis, not atherosclerotic.
So
And
you mean
here,
after echo, you should do an
yes,
echo first.
after confirmation of mitral stenosis, if mitral stenosis associated with TIA or stroke, it is indication for anticoagulation.
And the other indication for anticoagulation, this is one. The second indication for anticoagulation is
First, valvular EF, mitral stenosis, and here
perfect.
only
Yes,
vitamin
AF.
K antagonist.
Yep, AF
Yes,
and mitral valve replaced.
Replacement, yeah.
Yeah,
Post-valve replacement.
and there is
and,
thrombosis. If there is thrombosis,
Yes.
and also in severe left atrial dilatation by echo, more than 5 centimeter, it is an indication for anticoagulation.
okay. You are cardiologist, right? Dr. Ayman?
Yes.
Yeah, that's why.
Yes.
Okay, good. Okay, can you again
Okay.
enumerate all of them? So first of all, thrombosis. If there is thrombosis,
Yes.
and
If
if
there
the
is
valve,
yes.
yeah, go ahead. Mention it.
Okay. First indication is valvular EF. Valvular EF means only moderate to severe mitral stenosis and prosthetic mechanical valve, not
Yes.
all valvular EF. Okay. يعني mitral regurg not a valvular EF. Okay. Mitral regurg can take apixaban. Mechanical valve or mitral stenosis, apixaban or NOACs, dabigatran, rivaroxaban are contraindicated. Only vitamin K
Yeah,
antagonist.
perfect.
Okay, this is the first indication. Second indication, if there is embolic manifestation.
Yes.
Yani mitral stenosis is embolic manifestation.
Yes.
Third indication, in severe
Replacement.
left atrial
Oh,
dilatation. Yes.
okay. Severe left atrial dilatation and prosthetic valve.
Yes.
Okay.
Prosthetic mechanical valve, not all
Yeah, yeah.
يعني prosthetic not indicated except
But
in
tissue
the
valve
first
is
3
not
months.
indicated. Yes, tissue valve is not indicated. This is
Only
what you
first
mean.
3 months is post-operative. We
Then
use
aspirin. Yeah, then
anticoag.
aspirin long life.
Yes.
Okay, thank you, Dr. Aimi.
Thank you. Yes.
Then the indication, wait, stay with us. The time for surgical option in mitral stenosis.
Yes.
Who knows it? Dr. Ayman, wait, stay with us just to judge on answers, okay? Who said
Okay.
yes?
Symptomatic. I think first is symptomatic.
Perfect.
Mitral
This is
stenosis.
answer
Yeah.
for any valvular disease,
Yeah.
not only any symptomatic valvular heart disease is indication for
Yes.
surgery. What else?
I think the valve
Valve area below
area.
1
The valve
centimeter.
area, yes.
Perfect. Yes, valve area
Yes.
less than
1 centimeter.
1 centimeter. Fix it for any aortic or mitral. Make it the same answer. Less than 1 centimeter is indication. What else?
Heart failure, I think.
Okay, this is symptomatic.
Yeah, symptoms. Yes, you're right.
Okay, symptomatic means something manifested.
Yes,
And
yes.
the other indication, echo finding. One of them, the surface area. What else? Echo finding also.
Pulmonary hypertension.
Yeah, I guess pulmonary hypertension and the gradient.
Yes, the
About
valve gradient. Yes, you're right.
yeah,
I think 40 or something like that.
I will not mention numbers.
Gradient
I
for
will,
aortic stenosis.
that's why I will not mention number, just the gradient and I think velocity. I don't know if only in aortic
Yes, I
or
think it is valve gradient. Yes.
yeah. Okay,
I
one
think
more.
these are for aortic, the valvular gradient,
Aortic
and
only gradient.
yeah, not for
Okay,
mitral.
we'll ask Dr. Ayman now. We'll ask Dr. Ayman. The last thing is thrombotic, right?
Yes, embolic manifestation.
Yeah.
First, gradient and valve area. This is
Yeah.
for assessment of severity of mitral stenosis, not indication for surgery. Indication of surgery is different. Indication of surgery first, severe symptomatic mitral stenosis.
Okay, this is already
Okay.
done with this. Okay.
And the number now is less than 1.5, not one centimeter.
Really? Okay.
1.5 according to European and American guidelines.
Both of them. Okay.
Yes, and called significant mitral stenosis, not severe or moderate. It's called in guidelines significant mitral stenosis. So first indication is severe symptomatic mitral stenosis.
Yeah.
Second indication is severe asymptomatic with low risk of surgery, and the patient is low risk for surgery. Okay. Third indication is the patient has significant pulmonary hypertension. Pulmonary
Yes.
systolic pressure more than 50 millimeter mercury.
Okay.
Progression of atrial fibrillation, this is an indication for intervention.
Yes. And thrombosis.
Any episode of embolic manifestation in stroke or TIA.
Yeah.
This is an
And
indication.
one more indication for, and it's a big topic in the basis, which is
pregnancy and risk of hemodynamic instability.
You mean
يعني لو عيان significant mitral stenosis will plan to get pregnant, better انت to do intervention before.
Yeah, and should be tissue, right? In this patient should be tissue, not
preferable tissue لأن risk of
yeah.
mechanical thrombosis أثناء pregnancy very high.
Yes, perfect. Good point. I mean another topic, very big topic in basis and in cardiac station. It's indication also for surgery. Who knows it? Plus what we mentioned already. Challenging question.
There is sometimes surgery for closing of appendages and arterial, the left atrium. If the patient contraindicated to take anticoagulant.
Okay, this some details.
In F only.
Yeah, okay. What the indication of surgery in any valvular disease?
If there is regale, infective endocarditis,
Yes, infective endocarditis. This is what I need to say.
Yes.
Infective endocarditis. Any infective endocarditis indication for replacement, right?
Yes.
Okay.
No, not all infective endocarditis indicate surgery.
Okay.
Yes, there is indication for surgery in infective endocarditis.
Yeah, if there is failure of medical management and the indication, what we know in the infective endocarditis, there is some indication. But in the topic, yes, there is indication in the infective endocarditis, right? Dr. Ayman, right? So as a topic, infective endocarditis is indication in some situations, and we will mention
some situation,
them.
Yes.
Yeah, either the murmur and failure of management. There is indication, yes.
Yeah, if complicated by cardiogenic shock, this is the first indication.
Okay.
If complicated by pulmonary edema or resistant heart failure.
Perfect.
If the size of vegetation is very large and the risk of embolization is very high.
Yes.
If failure of medical therapy. These are the
aortic root abscess.
Yes.
But this is for aortic, not for mitral. Yes. atypical organism, fungal infection. There is indication for surgery in infective endocarditis, but as indication, you have to remember the infective endocarditis as indication for surgery in any mitral valve disease. Okay. We can also go through this topic to infective endocarditis, the DOC criteria and the management plan. It's not the time today. We have the case now, Dr. Thank you, everyone. Nice discussion for refreshment also. Did you write the case? Yes, young female. No, this is not the case. Dr. Ibrahim, we left
Yes,
you
I wrote
to,
the case.
where is it?
Old female, not young.
Old female, old female. I cannot see in the chat box. Is it in the WhatsApp?
No, in the chat here. I will send it again if you
Yeah,
didn't.
please send it, please. Okay. Anyone has comment about the discussion about metal stenosis? Dr. Hatem wrote, no AF, no heart failure, no atrial thrombosis, no need for anticoagulant here. No, we are talking in general, not on this case only. No CHAD score for mitral stenosis, exactly. TIA is indication to start TIA management, of course, after neurology opinion. Young female TIA contraceptive pills, yes, it's very important to specify in the management plan the team gynae for changing the pills or the way of contraception. Antiphospholipid connective tissue disease, familial hyperlipidemia, this is for the risk of thrombosis. Okay. Dr. Hatem said 1.5 centimeter. Okay, well, let's fix this number, 1.5 centimeter as mitral stenosis indication for significant mitral stenosis for surgery. Dr. Ibrahim, we are waiting for your case.
Yes.
Can you write it, please?
This is the repeat sending.
Indication, Dr. Hatem sent a figure. Indication for intervention focus on symptoms such as, by the way, any question about surgery or indication for surgery, start with symptomatic. It will just relieve you and will give you time to think about other causes. Symptomatic in the beginning of any answer for indication of surgery. Yeah, this is the option for surgery. Thank you, Dr. Hatem. Commissurectomy or replacement, and they prefer to do a small incision, not the cabbage one. There is a lot of option and new techniques. So the same case you wrote up, it's a house elderly woman become having malaise. So your case is malaise complain. Let's see, Mrs. again, Julia Adam.
Okay.
Elderly, how old? 70, 60,
70, okay.
70 years. Dr. Hoda, sorry for writing the case late.
Okay. I actually previously didn't know any specific analysis for malaise, but I will try my best. Okay.
You will do it. You are perfect.
Okay, inshallah. So
If
I
you're
will
ready,
prepare 2 minutes.
you will. Okay. I will receive some question or comments. Anyone has comment about previous case, about the discussion, anything? I will try to read the indication
Dr.
from Dr.
Bassem,
Hatem. Yes,
just
go
a
ahead.
question. I think Dr. Ayman said for bioprosthetic valve we give aspirin or something for 3 weeks, or I just want to correct, is it? I did not hear the information well.
You mean initially 3 months? 3 months.
For 3 months, aspirin or anticoagulation, you mean?
Anticoagulant.
Anticoagulant for
Initially.
3 months, and then we
Yes.
continue aspirin for life,
Aspirin,
yes?
lifelong. Yeah, lifelong, yes.
Okay, thank you.
And by the way, this is one of the advantage of tissue valve over the
Over the
mechanical valve.
prosthetic. Yes.
Yeah. So let's mention it because we are giving time to Dr. Hoda to prepare herself. What are the advantage of tissue over the mechanical and the mechanical over the tissue?
بس
The
في نقطة
durability.
في نقطة دكتور باسم، هو الانترفنشن الأول اللي بنعمله في الميترال ستينوزس نوت فالف ريبليسمنت، يعني هو بنعمل
Yes,
بالون
yes.
ميترال
Yeah.
كوميشريتومي لو الفالف فافورابل يعني اناتومي. في حاجة
Yeah.
اسمها ويلكن سكور بنحسبه، لو favorable بنعمل بالون مايترال
Yeah.
لو ما فيش كونترا انديكيشن،
Mhm.
عشان ما يبقاش كلام كله على الريبليسمنت. هو الريبليسمنت مش
No, no, no,
الأساس،
no.
وخصوصا في اليونج
Yes, yes,
فيميل.
yes, 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 yes. We are not talking only about the replacements. We can start by valvotomy, as you said, or commissurectomy. But we should have intact valve, right? Suppose not, the valve will not be diseased or sclerotic.
not intact، يعني هو في سكور بيتحسب. السكور ده بيعتمد على الفالف
This is,
كالسيفيكيشن.
yeah,
اه
this is cardiology details, right? I
انا
think,
اقصد بس ان الاوبشن
yeah,
الاساسي،
yeah,
يعني عشان ما
option,
نقولش
yeah,
بس فالف ريبليسمنت على طول. حتى في
okay,
الميترال ريجيرج الاوبشن الاساسي والبريفرابل اللي هو الريبير مش الريبليسمنت.
TAVI.
يعني الريبليسمنت في الميترال عموما، يعني في الاخر
Uh-huh.
لو في كونترا انديكيشن للريبير او
Perfect. Okay, so we will give the option first for either repair or valvotomy according to the disease. Then we will go to the last option, which is replacement,
Is there a
right?
difference between the repair and the commissurectomy or the valvotomy? ولا same?
Yes. Commissurectomy, I think we'll do it by balloon, or this is balloon valvotomy, Dr. Ayman. But if you could
يس ذا
please
سيم
explain
هم
the same.
كوميشريتومي
Yeah.
هو الفالفوتومي.
Mhm.
هو
No.
بالون بيوسع الميترال
Okay.
ستينوزس.
And the
انما
repair is different. Yeah.
الريبير ده حاجه تانية. الريبير ان الفالف واسع في الليفلت نوت، يعني مش بتقفل كويس، فبنضطر يتاخد غرز تضيق الفالف شويه او يتحط رينج. دي حاجه مختلفه تماما. ده في الميترال ريجيرج الريبير، في الميترال ريجيرج
Mhm.
الكوميشريتومي في في الميترال
Perfect.
ستينوزس.
Yes.
But it done
Okay.
by catheter صح؟ الفالفوتومي
Yes.
والمشرطومي ما في open surgery right؟
No surgery, no.
الفالفوتومي اللي هو البالون
Mhm.
بالكاستر،
Yes
انما
yes.
Yes.
الريبير بالسيرجري.
Yes.
وحاليا في ريبير بتستخدم جديد في العيان اللي هو
Mini
هاي ريسك، يعني مثلا 80
mini
سنه
surgery. Yeah.
سيفير مايترال ريجيرج، بيدخل بيعمل حاجه اسمها مايترال كليب اند تو اند ريبير، ده بالقسطره. دي حاجه جديده يعني.
Mhm.
طيب سؤال أخير، الدبل فالف إذا كان ستينوتيك عن ريجير عندي كيس فور سيرجر ولا ني؟ ولا على حسب الكرايتيريا الثانية؟
لا، هو من الكونترا انديكيشن للفالفوتومي اللي هو بالون كوميشريتومي، ان هو يكون فيه significant ريجيرج، يعني اكتر من مايلد ريجيرج، لان اصلا الكومبليكيشن بتاعه البالون ان انت تدخله في ريجيرج. فلو هو
لا
مودريت
Mhm.
أقصد
ريجيرج
السيرجر
ودخل
الريبليسمنت ميتاليك يعني أو
كونترا انديكيشن.
لا is it
بتسأل عليه
indicated
حاجه
يعني just double valve it is يعني it is indication just to be double valve يعني for replacement.
على حسب السيفيريتي. لو سيفير يبقى انديكيشن،
I
والانديكيشن
get
هيبقى هنا ريبليسمنت مش
yes, I got his question. He has double valve pathology, so it's now indication for surgery to do
بيرسي بس
H1.
يعني
يس.
دبل فالف بيرسي بس يعني من زون هذا الكرايتيريا بتاعت السيفيريتي.
لا بيخضع برضه للانديكيشن. كل واحده ليه انديكيشن. لو في انديكيشن للريبليسمنت سواء كان مايتر ستونز او مايتر ريجيرج بتعمل ريبليسمنت. انما لو ما فيش انديكيشن، عيان اسيمتوماتيك تماما وما فيش كومبليكيشن اللي احنا قلناها، ممكن ينتظر ويتعمل فولو اب لحد ما يظهر سيمتومز. احيانا يتعمل له ستريس تيست عشان يشوف بيحصل له ديزنيا مع
Mm.
الستريس ولا لا. فهو مش شرط يعني. لو دبل فالف ومودريت والعيان اسيمتوماتيك ما بيتعملش حاجه.
اوكي ثانك يو شكرا.
Perfect. Okay.
Okay, I can
Uh,
start for now.
okay. Dr. Ryan, we can postpone the discussion about the difference between the mechanical and the tissue valve now.
Sure دكتور
Okay.
باسم no worries.
Okay. After the scenario, remind me, please. Dr. Huda, you can start. Here you go.
Yes, hello. My name is Dr. Huda, one of the doctor in the clinic today. I'm talking to Miss Julia.
Yes, I'm Miss Yoda.
Miss Julia, we are here to discuss some issue related to your health condition. Is that okay with you?
Yes, okay.
So I have letter from your GP stating that you have a malaise. Can you tell me more about that?
Yes, I have this malaise about
Yes,
few months now, and
yes, and can you,
I feel loss of energy. And when I try to walk around my block or go to the grocery beside my house, I feel breathlessness.
right, and before this 2 month, everything was normal.
No, I had recurrent similar attacks from about 30 years.
30 years ago. And at that time, is it similar
Yes.
to this attack previously or different?
Yes, it was similar, but it wasn't like this nowadays, but it
Yes,
was similar.
yes. And at that time, are you admitted, investigated?
Yes, and
Okay, and giving
they
any
admit me.
diagnosis?
Yes, they put a diagnosis, but I don't remember the name.
Right. Okay. So now we would talk about this recent attack. Throughout this 2 months, you say that you have feeling unwell and you have this difficulty in breathing, right?
Yes,
And throughout this 2 months, is it increasing or the same?
it's increasing, yes.
Yes. And did
Now I
you notice?
can't walk more than a few meters.
Right. Okay. And anything increase this difficulty in breathing?
Only the movement.
Only on movement. Okay.
Yes.
Anything you have noticed that it may relieve it, this difficulty in breathing?
When I take rest or go to sleep, I feel better more usually.
When you go to sleep, you feel more well, right? Okay.
Yes.
So, okay. So, do you have with this difficulty in breathing any chest pain?
Rare?
Any chest pain?
Yes, rare. It's very rare that
Rare?
during attack I feel just discomfort, but very rare.
Right. Okay. And since when you have this chest pain?
And usually it comes when the attacks and I when with the attacks when I don't take my
Yes.
pills.
Right. Okay. And can you, so it's come on and off, right? And when you take certain pills, it's been more better, right?
Yes, I take
Can
it
you,
takes usually a few weeks and when I take my pills back and I
mhm,
feel
right. And can you tell me which pills that you have been used for this chest pain?
I don't know these
Right.
pills
Okay.
when I take I feel
Right.
just
Okay.
constipated and hard stool and abdominal
Right.
pain.
Right. So with this chest pain, can you describe me more about how it feels exactly?
What question?
What this pain, how does it feel, this chest pain when it's come? Is it a stabbing or it's dull pain
It's dull pain and it disappear
when you use
after
the tablets?
disappear after using
Right.
all the symptoms
Tablets.
disappear after using my pills for a few weeks.
Okay. Okay. Right. And does it go anywhere in your body, such as to your jaw or to your arms?
No,
Right.
and
And
it didn't bother me. The only thing bothering me now is the malaise, the loss of energy. I want to walk.
Yes, I can understand that. And with this difficulty, we will talk about more of this difficulty in breathing. Is it, you say it's mainly when you do activity and you walk. Does it relate to any position, mainly when you're sitting forward or lying flat on the bed?
No,
Does it associate with any cough,
no,
any heart raising?
sometimes, yes.
Okay, and sometimes when you have this heart raising, does it feel regular or irregular?
No, I didn't feel any irregularity.
Right. Okay. So, do you have any medical condition I should be aware of?
Only this condition.
All right. Okay. So, any surgical history in the past?
No, I didn't have any surgical history.
Right. Any medication that you have been used other than this pills that you will be taking?
I'm sorry, I forget to tell you. From time to time, I have blood from my nose.
Right. So sometimes you have blood from your nose. Any blood from any other sides from your body?
No,
All right. Okay. So do you use any blood thinning medication?
no,
Right. Okay. So we will come through this malaise. Do you have any episodes of throwing up?
sometimes when I take my pills, I feel like I'm going to throw up, but it's not.
Right. Okay. Right. Okay. Any skin rash?
I have around my mouth since my childhood. I have red spots around my mouth.
Okay. Can you show me this rash?
I'll
Okay.
try to.
Okay. Is it numbing? Is it numbing?
No,
Is it
it's not
itchy?
painful.
Is it itchy?
It's not painful.
Oozing blood sometimes?
Just from my nose.
All right. Okay. So I will ask you further. Any family condition or any disease run in your family?
Yes, I think my mother had the same problem.
Right. Okay. So now we'll ask you further. Any headache? Any headache?
No headache.
Any dizziness when you're changing your position from sitting to standing?
No,
Any changing in your water work?
no,
Any changing in the amount, color, or sometimes your water work containing the blood?
no change.
Okay. So any blood through your back passages?
Yes, no, not blood, just a change in color.
Okay, and how its color changed? It's more of a black color or a fresh blood? Can you describe me that?
It's usually a black and hard when I take my medication. That's why
Right.
I leave my medication from time to time.
Okay, any heartburn?
When I take my medication, I feel some heartburn, yes?
Yes. Okay. Okay. So any dryness in your skin?
No dryness on my skin.
Okay. Okay. Other than this medication that you've been used, any other medication or herbal medication?
Sometimes they give me vitamin.
Right. Okay. Any herbal medication?
No, I didn't use herbal medication.
Right. Any weather preference?
No weather preference.
Any lumps or bumps anywhere in your body?
No lumps or bumps.
Right. Okay. So I will ask you, Miss Julia, did you smoke?
No, I don't smoke.
Right. Do you drink alcohol?
No, I don't drink alcohol.
Right. And right. Okay. So I will ask you further about do you live alone? Are you having a job?
I'm retired.
Okay. And do you know, do you want any help in your daily activity at home?
Yes.
Right.
I want help in doing shopping, some shopping or going some groceries for me.
Okay. Okay, I can understand that. We will try if you have any difficulty in your social life, maybe we'll be involving a social worker to see how he will help us in this regard. So first, I will try now to examine you, Ms. Julia. I will start by looking to this rash and ask you any other rash other than this around your mouth.
Yes, there's also an enzyme on my tongue.
Right. Okay. And okay. And I will now checking for her eyes for any pallor or any jaundice.
Yes, there is pallor.
Okay, and we'll ask her, do you have any problem with how to see any difficult?
I am sending now the rash and the group. Okay.
Right. Okay. Then I will examine her pulse, any tachycardia, is it regular or not? And then I will go to her wrist, asking to measure blood pressure, sitting and standing. And then I will do a pronator drift and maybe checking the reflexes. After that, I will go to her chest, looking for any murmur, and then auscultate her chest for any crepitation. And then we'll offer to examine her tummy because she have abdominal pain, mainly in the gastric area, any tenderness.
No abdominal pain.
All right, and then I will go to her leg, checking for pitting edema.
Did you see the rash, please?
Yes. I will ask for any pitting edema, see any pitting edema or any discoloration in her leg. And yes, so I will ask her, do you have any high blood sugar or high blood pressure previously?
No high blood sugar. No high blood sugar or blood pressure.
Okay. Okay. And do you have any problem with how to see or sometimes abnormal vision?
No.
Right.
No.
Okay. So, Miss Julia, can I ask you what's your concern?
I want to improve without using these pills. These pills always causing pain on my tummy and causing severe hard stool. I can't withstand this. I wanna now about 30 years only these pills. Why they didn't change these pills?
Yes, I can understand
Sometimes
that.
they give me blood, but I didn't like it to be in the hospital and take a blood.
Why you don't want to get the blood?
They told me that you need to take a blood because your blood is very low.
Right. Okay. Okay. Okay, Miss Julia, after taking history from you and examine you, most likely you have a condition called hereditary hemorrhagic telangiectasia.
Yes,
And
I think
yes.
that's the name they said to me. Yeah.
Yes, and yes, it's
2 minutes.
I think you are now familiar with this condition, so it is a condition running in the families, and this is explaining the episodes of the malaise and the fatigue that you've been feel lately, and maybe the difficulty in breathing and rising in your heart. And I understand that you have been using this medication. I most likely it's an iron supplement. And yes, it could affect also your tummy, the heartburn you're feeling, and the hard stool. I can understand that. So what we will do is to involve a gut doctor and to see what other medication, that other form of iron, maybe supplementation or medication, we will involve to resolve the manifestation of these tablets and for you. Is that okay with you?
Okay.
Okay, so we will keep you under follow-up in the outpatient clinic involving team of a gut doctor and maybe yes, to see how we will help you in this regard.
Okay, doctor.
Okay. Any other concern? And thank you.
I want to ask. Oh no, I saw something similar to this rash on my son. Is it possible he has the same condition?
Okay, I want to just advise you maybe to see your son and to evaluate him further. It's maybe related or maybe not, but I can tell you this is a familial disease and run in family, and there is highly possibility that he have the same condition. So I
Right.
advise you to bring him to the clinic see the rash that he having, and yeah, we will see what will happen next.
I will send him.
Okay, time is up. Perfect, Dr. Dr. Huda, sorry, and Dr. Ibrahim. Let's start with your question.
For me,
Yeah,
she
start.
covered every aspect. I think she
No,
did very well.
not comment. Ask her about the general question.
Ask her, what's the mode of transmission of hereditary hemorrhagic telangiectasia?
Yes, it's an autosomal dominant condition.
Okay, and when you have a patient can't tolerate the oral iron, what's the alternate usually?
It could be IV iron supplementation,
Yes, IV iron supplementation.
Difirox or difirapine could be other choice.
Mhm.
Yes.
What's the commonest site of bleeding
Or could be
and hereditary hemorrhagic telangiectasia?
the most common side of bleeding, it's more of a GIT, but the most common and risky, it's I think CNS and cardiovascular. But the
I
most
think
common
the
is
commonest epistaxis and GIT, yes. That's what's your plan of management for me now, for the patient?
Yes. So first, educate a patient about her disease, and maybe we do a genetic counseling because she mentioned that her son also maybe have the same condition, and then the pharmacological treatment would be the management plan would be disease counseling and avoiding of any trauma and triggering factor. Avoiding.
What about the investigation?
Yes, the investigation would be complete blood count, renal function test, liver function test, and send for genetic test to confirm hereditary hemorrhagic telangiectasia, doing a stool analysis, and doing a jar urine examination, and yes, and checking the clotting factor and coagulation, clotting mainly factor, and
What's the indication of blood transfusion?
Sorry?
When the blood transfusion is indicated in these cases?
When the patient is hemodynamically unstable, vitally unstable, with massive hemorrhage, this would be an indication for blood transfusion.
Or severe symptomatic anemia.
Yes.
Okay, I put the blood transfusion at the end. I thought you didn't reach the case. That's why I tried to.
You give it me
more
clear throughout the history. Yes.
Okay. And you did very well.
Thank you.
Dr. Bassam, you have any comment?
Yeah, Dr. will ask one more minute. I will ask her some questions. Okay? You can hear me. Okay, Dr. Huda, what's energy you want to do? Hello, you can hear me?
Now
Hello?
I can hear. It was not clear. Yes.
Okay, what's the image? What scan you can do?
Sorry, I didn't hear you.
What image you can do for this patient?
Imaging. Yes,
Yeah.
this would involve colonoscopy and even endoscopy to explore any GIT involvement. And yes, it's maybe colonoscopy.
This is invasive.
Doctor, your voice was not clear.
What radiological option you can offer?
Um,
In-
in
What scan?
in this case, maybe because he mentioned that he have a heart raising, maybe an echo study and ECG.
Okay, perfect. This is disease of what, Dr. Huda?
Yes,
What is this disease nature, or what is the disease affecting?
it's affect multiple system.
Yeah,
Multi.
what's in vessels, right? Vessels.
Yes,
So what you will do? Scan, image, target scan.
yes.
Angiography, I guess.
Yes, CT angio.
Mm-hmm.
What you suspect in the GI? What the cause of bleeding in the GI?
Multiple telangiectasia and
Yes,
the lining of GIT.
angiodysplasia. So you will do CT angio, right?
Right. Okay.
And the chest also. You will do the same. And
Okay.
they are doing also for the AV malformation, because it might be AV malformation everywhere, in the lungs, in the GI, even in the brain, right?
Yes.
Perfect. Yes, exactly. AV malformation. In the heart also, they can do echo with bubble study, bubbling study, right?
Yes.
Okay. Perfect, Dr. Huda. Let's hear the comment from Dr. Ibrahim, then I will comment. Ibrahim, please.
Yes, I think everything was perfect, but sometimes, usually with patients like this, they give vitamin C, and sometimes they give also folic acid because of recurrent blood loss. And if the patient get multiple blood transfusion, he might have he is at risk of iron overload sometimes.
Hemochromatosis, secondary.
Yes.
Yeah. Anything else?
I think everything is covered.
Yeah, I
But
think also
the
Dr.
last thing, usually the neurology doctor try to avoid scanning for any AV malformation because the cost, the danger of or side effect of surgical intervention for silent AV malformation or even aneurysm more than the risk of rupture of this aneurysm or malformation.
You mean they will not interfere, but they will diagnose it?
They will not screen also.
Why?
Even in the case of polycystic kidney, they do not screen the patient, except if he's at high risk, because that is a decision to intervene very very rare.
Okay, I got it. But if she has headache, they will screen, right?
Hey,
Rule
yeah,
out subarachnoid. Okay.
yes.
Okay. Any other comment? Okay. Thank you, Dr. Ibrahim. Very nice case. In such
Welcome.
age, yeah, in such age, suppose it would be younger because it's an inherited condition. But
That's why I said 30 years.
yeah, it's 30 or 70.
I said 30 years. Since 30 years, I'm taking these pills. I don't
Okay,
want to
for the
take it
iron, you
anymore.
mean? Yeah.
Yes.
Yeah, it was tricky to distract Dr. Huda, but she kept calm and she reached the diagnosis. The, sorry, Doctor. Okay, my mistake. I think the analysis was okay. The system review also, the approach, and the medication. You analyze everything in this scenario. the surgical, the medical, the past medical condition. I don't have comment for Dr. Huda today. She offer also support to cope with her life. Always when you have such age and the exam, ask about how you cope with your daily activity. They don't care about money now or financial support. They care about someone to help them to cope with the daily activity, how to cook, how to go to the bathroom, how she can walk. These things much better than the money. They don't need financial support. They need someone or something to help with and to cope with her daily activity. She was concerned about the shopping, so you can help her in this point. Someone to help her or a social worker to help you in this regards. And don't go deep. Don't say I will send someone. No, we will address this point with our social worker. That's it. She doesn't need any sick leave because she's already retired. And screening, I think in this age, she already 70 years. If you want to counsel, yes, but if you want to screen, it's already diagnosed with the clinically. So you can counsel her about genetic counseling for the offsprings, for her child or her sons and the next generation. But to do genetic testing, okay, offer it, but it's not a necessary test, I guess. Okay. Well done, Dr. Huda. Any comments or question, Dr. Huda?
No, thank you.
Yeah, welcome. And you catch also the anemia finding here, the pallor, the dizziness from sitting, right? Because what
By
she
the
has
way,
now is related
the
to the
angina is one of the
anemia.
symptoms of
Yeah,
anemia.
Dr. Ibrahim.
And you might have
Angina, yeah,
high
of course.
pulse and you might have murmur. But I didn't like to
Perfect.
put these things.
No worry, you can put it or you can add it at the end, as you said now. So we will refresh
I will distract
our
her if
mind
I
about this topic. No, it's hemic murmur. You should listen to the heart in this condition.
yes.
Hemic murmur or functional murmur, it's supposed to be here or on auscultation.
I thought also she will pay attention to the heart rate also, the pulse rate. Maybe it will be like
Yeah,
cardiac
tachycardia,
and
yes.
yes, high volume and all these things. So she
Perfect,
skipped
yes.
that one, yeah.
She didn't do, you mean?
She did it, but she skipped the finding. She did not ask for the finding. She did not ask him what is the pulse, how is the volume, and all these things.
Yeah,
So she said, "I will ask about the pulse and all," and she skipped the finding.
yes. By the way, in online session, we just ask for the anemia and we are skipping. So we have to train what do you mean by asking this question, what you want to know. As Dr. Maha said, I want to know the pulse volume, the
Yes,
collapsibility.
at least the relative things, yani.
Exactly, yes. We have to train about that because in the exam you will not ask the surrogate or the patient and will tell him how is your pulse. No, you will do the test itself. So train yourself to ask about every single test in the online to be ready for the exam itself. Okay. This is also for surrogates. If she asks you, I want to know the pulse, don't tell her the pulse is okay. No, tell her what you want to know exactly in the pulse. If she said, I want to know the rate, yes, I will tell her the rate. What else? The regularity, yes. What else? The symmetry, yes. What else? The volume, like this. So don't just give her the pulse is okay. No, tell her what you want to know in the pulse. Okay, as Dr. Maha said. It's not only the pulse, I mean anything else. The neurological examination. We are asking each other how the power. No, tell her what you want to know. Where exactly you want to examine, distal or proximal, and so on. The sensation, I want to examine the sensation. Okay, what do you mean by sensation? So either superficial or deep. You have to ask the candidate what he meant by this examination because again in the exam you will be with the patient alone No one will either give you a clue or help you. Clear now? This is for all of us, not only for today session.
Yes, and Dr.
Okay.
Basim, I think no need for the genetic testing for the son
Yes,
even. Okay? Yes, because it is just clinical diagnosis,
mm,
and the genetic testing will not affect the prognosis and will not affect the management plan.
yes, I agree. I said also this genetic testing is not in this condition. Either to say genetic counseling, not testing itself. Because the
Yes.
diagnosis is known. Telangiectasia
Oh,
in the lips and the face and the tongue. That's it. It's already
yes,
diagnosed. And you can do some CT to diagnose the AV malformation everywhere.
yes, you're right.
But yeah, you can say for the next generation genetic counseling if they want to avoid the disease or the
Okay,
inheritance of the disease. Yes. Thank you, Dr. Ma.
thank you.
Any other question or comment?
Dr. Basim, I just want to add.
Yes. Dr.
So I
Ryan, go.
think, yeah, Dr. Huda did very well. Just a few
Mhm.
comments. I
Yes.
felt initially she was rushing the patient a little bit to get the diagnosis. She interrupted the
Yeah.
patient a few times. So just pay attention to that because they don't like it. So maybe
Yes, you're right. She interrupted the patient a lot.
a lot, yeah. So
Okay.
Yeah.
maybe
No, I
because of the
shouldn't
online.
interrupt. No, I know I should not interrupt. I really know it's a
You
communication
was
skill.
in hurry, Dr. Huda. You did
No,
really very
but
well, but you was in
they
hurry.
take yes, but they take too much time to answer me. So I
Maybe there
try
is lagging, yes, in the internet. I
Maybe
believe there is some lagging.
because yesterday or the day before I try to ask questions and I have a lot of complaint and it's too long. I don't think it's in the actual exam would
No,
be
no,
that
it
long.
will not be like this. No, it will be
most
better
likely will
like
not
this.
be. Yeah, most likely.
Yes,
But just pay attention that
yes,
it can
thank
happen sometimes. The surrogate might be a little bit slow. So just don't try your best. Never let them finish their sentence.
Yeah.
This is one thing. Another thing is when he asked you about the plan of management, he did not ask about investigations first. He just told you what is your plan of management. Make sure you mention investigations first and then your plan of management, because this is counted. Maybe the examiner forgot, or maybe actually management means investigation and treatment, both of them, not only the treatment plan. So you might miss this point if you just said the treatment plan without mentioning investigations.
Right.
Another thing, prioritize your investigations. So this patient had black stool, so the priority will be for upper endoscopy rather than colonoscopy. I think you mentioned colonoscopy first because they also want you to prioritize your investigations. So you can mention upper endoscopy in view of the black stool, but can consider colonoscopy later on, for example, if there is any fresh blood. Also, when you mentioned the management, when he asked you if she did not tolerate oral iron, you said iron replacement, IV iron replacement, and then you mentioned like deferoxamine. So pay attention that deferoxamine is not an iron treatment, it's actually an iron chelator.
Yes, right.
Okay?
Yes,
Yeah.
thank
So pay
you.
attention to simple points that might actually affect the scoring. Otherwise, you
Yes.
did a great job, actually, mashallah.
Yeah.
Yes, but I have
By
a
the way,
nice note.
just a
Thank you.
comment for me. There is no role for colonoscopy or upper GIT endoscopy and hereditary telangiectasia, except if you found a severe bleeding, you might try to find only single area to do intervention. But usually, the only treatment for bleeding of hereditary hemorrhagic telangiectasia is iron supplement.
Okay.
Do you hear me?
Yeah.
Yes, thank you.
No specific treatment in this condition unless there is some vessels could be accessed, so we can do cautery, like epistaxis in the nose
Yes.
or
When
in
you
the
find
tongue.
massive hemorrhage. Okay. I know. There is no voice.
Yes, we are hearing you, doctor. Yeah, thank you so much. I think maybe
Okay.
Dr. Basim is connected, or I don't know.
We can't end on behalf of him. Do you left?
Hello? Sorry, I receive a call. You can hear me now?
Yes.
Yes, yes.
Yeah, I was talking about pushing the sorry get to mention the disease name. It was so funny when Dr. Ibrahim told her I cannot remember the name, but when she said the diagnosis, he said, or the surrogate said, "Yeah, this is the disease I was diagnosed with." It was
It
like
happens.
yeah,
She reminded me.
but yeah, you help her at the end to give her the correct answer. Anyway, any
There you
question
go.
for the previous case before? Thank you, Dr. Ibrahim and Dr. Huda. Any question? We will discuss with Dr. Ryan the difference between tissue and metallic valve, the last point in this meeting, then we will end. Are you here, Dr. Ryan? I remember.
Yes, Dr.
Yeah.
Benson.
Okay, tell me.
Your voice is cutting actually, Dr. Bassel. It's breaking every now and then. I cannot hear anything now. If you are busy, we can send it in the group.
No. Another call. But yeah, I'm with you now.
Okay.
Go ahead.
So I remember that for the durability,
Yeah.
So for the prosthetic valve, around 30 years, and
Yeah.
I mean for the bioprosthetic valve, 30 years.
Don't mention years. It's longer. That's it. No
Longer,
need to say
yes.
30. Yeah, longer. Okay.
Yes.
And
so the patient who are at risk of bleeding, so we will go for the bioprosthetic rather than the other one, the
you mean the
mechanical
anticoagulant? Yes.
anticoagulant.
So the anticoagulant
And-
option. Yes.
But survival, both of them, they have the same survival.
You mean
As
the
far as I
durability
remember,
different
Like-
than the
Yes, that's right.
both have survival is equal, but the time that
yeah they change. So you will change the tissue valve, but the metallic will
la-
be longer.
will
Yeah.
last longer. Yes,
The
yes.
anticoagulant, yes, in the
And-
in favor
of the metallic valve metallic valve
Tissue.
warfarin. What is
tissue
it?
valve. So tissue valve, no anticoagulant, but
Yes.
in the
Yes.
prosthetic there is anticoagulant, and the
Yes.
anticoagulant having risk of bleeding and so on.
Yes.
Yeah, this is the main difference, by the way. They will not ask more about the difference.
And usually the age, old age patient, we go for
Perfect,
the
yeah.
bioprosthetic,
The old will be for
the tissue.
Bioprosthetic.
yes,
Yes.
exactly.
Yes.
You make it the opposite.
And young female, you want
No, I said-
if she
I said
wants
bio.
to get children also.
Okay, bio, okay.
Yeah.
So Dr. Ibrahim again?
Young female also, if she wants to get children,
Yes. Yeah.
Yes.
they prefer bioprosthetic
Bioprosthetic,
to avoid
yes.
warfarin.
Perfect.
Yes.
And also they can do, as Dr. Ayman said, the option of repair and mini surgery. Okay. Thank you, everyone. Anyone has comment or question before ending the session? It was
Thank
really amazing and nice session, Dr. Ibrahim and Dr. Huda. Very also perfect
Best.
performance. Yes, Dr. Ayman.
I want to ask in hereditary hemorrhagic telangiectasia,
Yes.
is there any role for genetic testing for diagnosis, or
Yeah,
just
I
we
answer you.
depend on
Yeah.
criteria?
It's one of the criteria, by the way. I answered your I forgot to answer your question by comment, but I answer in the chat box. You said, is it necessary? Yes, it's for both to confirm the diagnosis as hereditary hemorrhagic telangiectasia. It's one of the criteria. It's 2 out of 3, right? Family members and
3 out of 4, yes.
3 out of 4, yes. One of them the genetic testing or family member, presence of family member. So if you have a genetic testing, it could be with the criteria. Okay. But if
it's
you have
not mentioned
not
as a
mentioned as
criteria.
genetic, yeah, it's not as genetic. But if family history how to know the family history. If for example you have adopted patient, you will do the genetic testing, of course. You got it now? If you have family
Yes.
member with the same disease, so it's no need to do the genetic. But some patients will tell you, I am adopted, doctor. This time you will do the genetic testing,
Mm.
and it will be one of the criteria. Clear?
Yes, clear.
Okay.
But Dr.
Thank you,
Basim,
Dr.
if we found
Yes, yes.
the other three criteria of epistaxis
That's
and the
yes,
AV
yes.
malformation without the family history, it will be facing the criteria 3
Yeah,
out of 4. Yeah,
yes,
so maybe it is not that much necessary if we have
exactly.
the full criteria, yani 3 out
Yes,
of 4. Like
yes.
if we
Agreed.
find the epistaxis, telangiectasias, and visceral lesions, so no need to go for the genetic testing or the family history and all, because
Yeah,
3
it's
out of 4 criteria is
yes.
diagnostic.
Agree. Yes, agree, Dr. Ma. Yes, perfect to mention. So 3 out of 4, maybe you skip this if you have 3 of the others. But if you have 2 and you want the third, and for example, you don't have epistaxis and you want to confirm with the family history, you can have the test or genetic or the family history itself. If adopted patient, you can go for the genetic. Okay. Thank you, Dr. Daria said this is the clinical diagnosis, of course. Yeah, thank you. It's a very nice session. I agree with you, Dr. Ryan. Thank you for waiting all this time with me, for the attendance. Thank you, Dr. Huda and Dr. Ibrahim, and all the attendance today. Thank you. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.